So thanks, Hemant, for asking me to talk about this topic, of which I know very little, but it made me read about it. I learned about how to do a total knee replacement nearly 30 years ago, and I have to confess, I haven't really changed too much about my way of doing so. And I suppose this is really a good eye-opener for me to get up to date. And there's some good evidence that we really do need to change the way we do knee replacements. But as with everything about implants, we need proof and we need longevity. So that's one of the real drawbacks. So disclosures again. So how were knee replacements originally designed? Well, the whole idea really, I think, with safety in mind, is that the hip is above the knee, is above the ankle in a nice straight line, lots of static inline stability. So the hip-knee ankle angle was 0, and it would mean that there was perpendicular cuts to the mechanical axes of the femur and the tibia, and that also in flexion and extension to make an equalized gap. And this was the way that was done, and still is largely, and accounts for 95% of the data on the NJR and also the Australian and New Zealand joint registries. When the population is looked at, however, as Bellarmine's paper amongst others have shown, is that alignment doesn't really exist as the norm. There's a scatter around alignments, and as the recently talked about CPAC classifications tell us, there are many different alignments of knees, and it certainly isn't the case that the majority are like that. And the joint line isn't therefore perpendicular, and Amir was mentioning earlier that study with Amos and Williams. There's that 3-degree angle, and really that joint line can vary by that gap according to whether you go for the medial plateau or the lateral plateau. And also, to achieve that equalization, you might really have to go against the grain and alter the soft tissues. You might need to relax or even fully release the MCL to achieve that equalization. So really, and I suppose this is one of the points, is it's systematic, which in some ways is safe, but in other ways is sort of baby and bathwater scenario. You're sacrificing things which you've not really looked at carefully. One size fits all, and any individuality of the patient's kinetics is therefore sacrificed. And so is this the case, therefore, that why we have the limitation on success and satisfaction in knee replacement surgery? This paper from over 10 years ago, Paul Baker and Paul Gregg, looking at satisfaction. 10,000 patients from the National Joint Registry were all, and they got about 80%, I think, or more of patients replying. 87%, very high response actually, and satisfaction rate showing that, well, it's a good operation, but nearly 20% of patients say that they weren't satisfied. And similarly, other papers have shown, Lingard, Bourne, and Nam have shown in big journal publications, this high levels of dissatisfaction, the 25% never again, not over my dead body, and 55% with residual symptoms. So, what's the dream? Well, this is what kinematic alignment is about. So the idea is to personalize, individualize, and make things patient-specific. Originally described by Howell, and this was started back in 2006. This paper mentioned at the bottom was published 2008. He described 3 axes, the condylar, the patellar, and the tibial rotation axis, although most would now really regard this as a recreation of the native joint line with the components. And it's all about bringing together these 3 elements, the morphology, which is the shape of the bone, the soft tissue tension, and also the alignment, and a combination of the 3. So this is Howell talking about the 3 axes, which are shown on the left there, the condylar axis, the patellar axis, and then that yellow line being the tibial pivot axis. And looking at the description of mechanical and kinematic, he's very much describing TKA with a mechanical alignment as being a crooked operation, crooked joint line, crooked axes. So the kinematic approach has increased in popularity in recent years, and as I said, it's a bringing together of these 3 elements. Really, one depends on the other, depends on the other. So whichever one you start with, it affects the others. So they have to work together. But the idea is that because you achieve those 3 things in harmony, that you will then ultimately achieve the unique kinematics for the patient's knee. There have been derivatives of the initial kinematic approach, which leads to a bit of confusion, so I'll try and explain what those derivatives are. So the first step had always been to make the resection from the femur, and to do this using a component which was adjusted to the amount of wear, so 2 millimeters taken off for the cartilage if it was worn through. On the left-hand side of this diagram, you see the calipered approach, which is simply, as the name describes, measuring the thickness with a caliper for your resection, based first on the femur. Then the adaptation of using a soft tissue respecting kinematic alignment, which involves longitudinal traction to actually tense out those soft tissues, which can have its dangers of over-distraction, and that's perhaps one to look out for. And then maybe a slightly false interposition of a restricted zone, just to make it a little bit safer, introducing a narrower corridor of mechanical alignment so that you don't get some wacky-looking reproductions of the patient's original. And then the functional alignment, the areas where we can use navigation, computer assist, or even robotics, where we can actually change intraoperatively. And then finally, the inverse, where the tibia was cut first. But there's still controversy, even between proponents of kinematic alignment and the so-called unrestricted kinematic alignment and the restricted kinematic alignment. Restricted, in a sense, is still not completely letting go and just being a little bit worried in case you can introduce some major mechanical malalignment which may produce loosening or some other dysfunction. So there's a little bit of doubt amongst others on this. But the editorial at the top there, with Stephen Howell and latterly Michael Hirschman, who are a big name on alignment in knee replacement, are very much in favor of going ahead with unrestricted alignment. And they would point to the high long-term survivorship at 7, 13, and right out to 16 years, with high forgotten joint scores and Oxford knee scores for the unrestricted kinematic alignment. And the restoration, of course, of the in vivo kinematics and also reproducing the original medial and lateral compartment forces. Many of the studies reported in this editorial are actually looking at the mechanical alignment, which really goes pretty far out on each side. 9 degrees of varus at one way and 4 degrees of valgus the other way. But you know, these alignments are comparable to those of the non-osteoarthritic knee, the normal knee alignment that we see in the population. And study of the tibial base plates with RSA has shown very low rates of loosening, which were comparable or even less than similar studies for mechanically aligned total knee replacement, even up to 9 degrees of varus alignment. So there's no suggestion at all really that these things are rattling around and falling out just because you're actually keeping the patient's original kinematic alignments. So when it was introduced in 2006, there's always that in healthcare, we've got to be very careful, particularly with implants, but this is a kind of a way of implanting the implant. You've got to be very careful how you do things. So there's a lot of natural cynicism, and I don't think it's wrong to have that cynicism or questioning attitude. So a paper was published in the Journal of Arthroplasty. I think this was back in 2010. I'm not sure, I can't remember exactly. But they said that we must really be setting the alignment within this narrow range of 3 degrees. And what about failure? And what about medical legal action? And at the time, there was no FDA or CE approval. So consequently, there was quite a limited uptake of this procedure, and the safe zones were introduced with plus or minus 5 degrees from the mechanical axis. Then it was approved, and surgeons who came into performing this technique actually found it really relatively easy to adopt. And the use of reference landmarks, the ability to bolt the jig onto the femur, and then the way of sort of reassuring yourself as you went through with caliper measurements and real-time reassurance that things were going well was quite easy for surgeons to adopt. They found that even in the worst case scenarios with this caliper resection technique, that the resection inaccuracy in the worst case scenario was actually slightly better than the worst case in a robotic-controlled mechanical axis TKA. So really, it's not that bad if you don't get it bang on. So, again, with this technique, you're cutting millimeters and marking those millimeters carefully rather than following angles, which can lead to bigger millimeter discrepancies. And there's no need to locate the femoral head and the ankle centers. So looking at the systematic reviews and the evidence, this was the most recently published meta-analysis. And it does suggest with WOMAC and Oxford Knee Score that there is better medium-term reporting of outcome. The forgotten joint scores and the revision and reoperation rate was no different. And they summarized that further research was required. There were 5 previous meta-analyses which hadn't shown much more than, as you'd expect in short-term outcomes, slight improvement. And their own big study was not enhanced by the attempt to use trial sequential analysis, which is a way of getting greater power. So beyond the short to mid-term, it's not possible to say there's any long-term benefit until we have more evidence. But why would I say to you, have a kinematically aligned total knee replacement rather than a mechanically aligned TKA? Well, really, mechanical alignment comes from an old-fashioned idea, which was built on caution and the idea of having things in a straight line. Nothing wrong with that. It's what orthopedics is all about. But it's predicated on the idea that we're all the same, which we're clearly not. And only 3.2% of healthy non-arthritic knees actually fall within that mechanical alignment range. And the soft tissues that you need to release to achieve that knee replacement may well be the reason for the negative post-operative results that we're seeing in 20% of patients. So the kinematically aligned total knee replacement recognizes this considerable phenotypic variability. If you, again, looking at the CPAC system, there's so many different varieties out there, and it aims to reproduce your individual alignment, which makes complete sense. And reproducing the joint line more accurately and maintaining the soft tissue tension is more likely to be enhancing your PROMs at the end of it all. And that is seen really as the tension in the tissues with the alignment is seen as the most important factor in mitigating the ongoing levels of patient dissatisfaction. And as I said earlier, the early to mid-term results support the use of kinematic alignment over the mechanical alignment. So just a couple of little things around knee replacement and osteotomy, because I can't do a talk without mentioning osteotomy, sorry. So this was a patient who I would have done a total knee replacement on just about every day of the week until he told me that he couldn't have a knee replacement because he was a roofer. And in fact, he says that he's very good on the apex of a roof, very stable when he stands on it, maybe for obvious reasons. But he wanted an operation to get him out of pain. And we just did a deal, but he also wanted both operations at the same time. So we said we'd do that. So we did bilateral medial open wedge high tibial osteotomies. And as good patients do, he was a good patient, so this was 12 weeks after surgery. But they're very well trained. But the point I was going to make here was there's no, how would you do kinematic alignment on this? I'm not making this a point for kinematic alignment. What I'm saying here is with all that massive bone loss, I just think osteotomy is so good in this particular situation at giving him back his metaphysis and actually making a knee replacement a much easier prospect. That's one point. And then a second point I was going to make, there's 3 cases that we've had, and the index surgery was never performed in Carlisle, I hasten to mention. But we've had 3 cases very much the same, and this is probably a criticism of the systematic mechanical alignment, and either a lazy surgeon or a not trained surgeon or somebody having a bad day. But these are 3 operations which I think, if we were doing things individually, these things probably wouldn't happen. So this patient's ended up with that, but we did a medial closing wedge distal femoral osteotomy, and he was very happy. This was case 2, a patient, again, from another part of the country who was sent for an opinion, and she had the same procedure, a medial closing wedge osteotomy, has done very well. And the third case, the only one I have a video for, this was actually the one I did about 10 years ago. And the point here really is systematic mechanical alignment. The process has done that. She's had a femoral cut consistent with either a short rod or just a misplaced rod going into her distal femur, instead of that, which would have left her with a much better shape to the end of her femur. So she had that as well. She's had the medial closing wedge osteotomy, and she's a very happy bunny now as a result. So thanks for your attention.
So thank you so much, Matt. And I think Carlisle is the place I did my first job when I came to England as an SHO, and I have very fond memories of the place, Cumberland Infirmary. So thank you for coming. And I think also thank you for doing some of my job from this talk. So I'm here to convince you that all osteotomy should be corrected. That's my objective. And hopefully I should be looking, give you my side of argument and say that is a good idea. Now, I'll tell you the story. So this was a chap came to me in 2009. Actually, he went to knee team for a knee replacement, and they said, probably not a good idea. And they called me saying that, do you think you can correct the knee? So I said, yeah. So we corrected the knee, and which was the obvious thing to do. Have to release the parallel nerve and all that because it's quite high there. And there was a bit of a struggle because I didn't put the frame properly, but that's a different story. And his pain disappeared. It wasn't offloaded, and I wasn't planning to do an HTO type because I thought he's coming for a knee, his knee is gone. Just let me put it in the center so he got a proper knee. And then in 2017, he came to Miss Mulder's clinic and said that my right knee hurts, not the left one, his right knee hurts. And I have to say that since then, he still hasn't the knee replacement on his left side, which was corrected. Now, this is not the every case, but this is just an example that sometimes things can happen. Body has a brilliant adaptive power and change, which some of it we don't understand. So the knees, if it's working fine, is brilliant, no problems. Absolutely fine, no problems. But if it's not working, then there's a lot of problems can happen. And that becomes a challenge. And especially true for young patient. If they have a deformity in young patient, then it is a problem because we're doing more knees in young patients. And if you look at it, there are two large studies, one from New Zealand for 100,000 knees and 20,000, and then one from Oxford. If you look at it, the lifetime cumulative risk of young people knee replacement below 54 is quite high actually, more in males, but in females is high as well. So if you do a young patient with a deformity, it's probably not a good idea to do a knee replacement anyway. So if you look at a knee replacement, what is actually knee replacement? Knee replacement is a salvage surgery because we can't do anything, so we chop the bone onto the bin and then put in a shiny new knee. That works fine because that works very well. And it is not in true sense a treatment, but it gives us the desired result because what patients do is patients go back to functioning and are able to do most of the things. But it is quite important that a pain-free native knee always works better than a total knee replacement. And the number of studies, one I'm going to quote, and Matt has shown you some studies that the dissatisfaction rate is quite high. Now, if you look at how the weight bearing passes through, and this is a thesis done in New York, I think Robert Roswell's group was part of this. And if you look at it, in a neutral alignment, when we say 0, about 60% of the waste passes from the medial side. If you go slight varus, it increases. And in 5 degrees, pretty much most of the weight goes through in the inside of the knee. If you have to offload the knee, which we do on sort of, and this is just cadaveric study, so I have to say you have to take this with a slight pinch of salt because in the true loading in a sense how it comes to the human extrapolation, the living people, it's not exact, but it gives you an idea. You have to go a lot way to offload the knee completely. And if you have to completely offload the medial side, that doesn't happen in practical sense. Now, if you look at the functions as we looked at it, that most of the patients is actually do well. And the question is that is the function important or the technicality is important? So most of the knees are done with the mechanical alignment. And despite a good looking knee, a lot of people are unhappy. So up to 1 in 3, to 80 to 75 to 80% are happy. So actually 1 in 4 or 1 in 3 patients, 1 in 5 patients may be unhappy, which is a significant number. And this is a general dissatisfaction. There are a number of factors. So in a sense, it could be clicking, clunking, and I don't feel like a normal knee, all kind of things can happen. If you look at the kinematically aligned knees, they actually have a better outcome and patient feel the leg belongs to them. So functionally, they are much better. And 10 years results are similar, but the data is limited. So all the data what we have is actually pretty much single, I think, Howell study and probably one more. There are 2 studies. The Howell is only for a long-term follow-up. They all are short-term follow-ups or medium-term follow-ups. But our problem is that all these studies are on normal knees. All the kinematic knees results are on normal knees. And if you look at all the data which is related to the pre-existing deformity or deformity, there is very little data where there's a deformity and a kinematic knee is done. If you look at the mechanical knee, the results, there are some data, but it's quite sparse. And the other thing is we don't know what is the safe amount of deformity you can leave behind or incorporate into the kinematic knee. So it varies, and I think range has gone up up to about 9 degrees, as you mentioned, can be incorporated. But we still don't know that is a 9, or it can be 11, or it can be 7. We don't know the long-term outcomes. If you look at the normal population, and again, I'm just trying to re-emphasize the point again, that this study looked at the total knee replacement and matched them in a large cohort of patients, identified similar number of patients. And they did SF12 at 1 year, at 2 years. And the results suggest that physical component actually improved as the preoperative level, but still not the same as to the normal native age-matched control. So it gets better, but it's not the normal knee. So I'll come back to the same point again, that a knee replacement improves your function, but a pain-free pain-free native knee is actually functions better than a total knee replacement. So when to correct the deformity? I think all young patients below 60 should have osteotomies and correction of the deformity. And if they're physiologically young and very active, then you can increase the age up to 65, maybe longer actually. I think Matt does a lot older at times. And Teramoto in Japan, he does to about 75, 80. I don't think he ever does a knee replacement or suggests any knee replacements. And if deformity is complex, then it's probably worthwhile to do a deformity correction first, because then you have a much more easier way and simpler way to give a knee replacement in a desired position. And sometimes when knee replacement surgeons are uncomfortable, so they might not incorporate. What do we do? In those cases, if there are any doubts, have an MDT approach. We can discuss with the whole team and then make a decision. Or you can say, well, there's a deformity, some doubts, why not correct the deformity first and then do a knee replacement? And this is an example which came to me quite a few years ago. 65-year-old lady, knee surgeons were quite unhappy. They said, well, actually, they weren't unhappy. They weren't sure, actually. And they said, what do you think? I said, yeah, if you want, I can correct the deformity. And correct the deformity it was a fixator-assisted internal fixation, because she wouldn't have coped with the frame at all. So we did that, and she still hasn't had a knee replacement. Now, it can fail tomorrow and she had a knee replacement, but when she has a knee replacement, it would be in a knee which has got a decent bone stock, and you can do whichever belief you have, kinematic or mechanically aligned, you believe you can do that. The level of deformity also matters. If the deformity is closer to the knee, it has much more effect on the mechanical axis, and therefore your sections in the joint would be different as compared to somebody, some deformities very distal or actually away from the knee, either very proximal or distal. So this is the same 20 degrees deformity. And if you look at it, that same deformity which has got at the level, if it's a knee, it's got a huge effect on MAD, but it comes down to the ankle, has a very little effect on MAD. So this is also important. When to ignore the deformities? The same patient I did, so Liz did this knee replacement, and it was minor, increase in MAD. So it's just a standard knee. I think she did computer navigated, and it is functioning fine. Now, if you incorporate the deformity into the knee, if you're doing mechanically aligned, so what happens is that if there is ligaments which you have to balance. So if it's a tibia, you can do asymmetrical dissection, ligaments are down, and it affects the flexion and extension gap equally, and therefore what happens is that the balancing the knee is much easier. If you're doing the femur, there are two problems. One, the ligaments, the amount of bone you can cut is small, and therefore you can't go very high, so the incorporation of deformity is much less. But also, it's difficult to balance because what happens is that if it is an extension, so this is the situation, you say that you do the asymmetric cuts, and then you release your MCL, and you balance your knee in extension. When it comes to flexion, you do a standard cut. So when you finish, you have an imbalance in flexion as compared to extension. And so asymmetric cuts can be useful, but they can be challenging. And I think a very experienced knee surgeon might be able to overcome it, but it can be very challenging to balance the knee in flexion and extension. So in summary, kinematic knee replacement has good outcomes, but there's very little data on pre-existing deformities or incorporation of deformities, and we need to have long-term outcomes. And therefore, all significant deformities or any deformities, especially in a young patient, should have a two-stage procedure. All deformities should be corrected. And I believe that in significant number of patients, not in all, the knee replacement would be delayed. And when it happens, there's a decent alignment, bone stock, and you can do the job what you want. And also, if you can delay it, they will be in much better way because native knee functions better. Thank you so much.